Hello, Reena.
Hi, sir.
I think Ashok sir will be joining little late, no?
Yes, sir. We'll start, sir.
Okay. Already 20 people joined. You wait for another 2 minutes, 1 minute
Okay.
or something like that. And
Okay,
then
sir.
I think better we start.
Okay, sir.
Reena, I think now we can start it, I think.
Okay. Okay.
Dr.
Okay.
Samad? Dr. Samad,
Yes, yes, of course.
can we start now, sir? Okay, sir. Sorry.
Okay.
Okay, sir. Good evening, everyone. Myself, Dr. Mary Reena. I will be presenting the topic on MRI Brain in HIE Neonates. Moderators, Dr. J. Ashok Raja, Head and Associate Professor, and Dr. Subodh Shetty, Assistant Professor, Madurai Medical College. Today, we'll be covering the topic under the following headings: Introduction, why MRI Brain, the normal anatomy of internal capsule and basal ganglia, MR spectroscopy, patterns of injury, MRI changes in HIE both in term and preterm neonates, MRI scoring system, and differential diagnosis. Coming to the introduction, MRI provides consistent delineation, particularly involvement of cerebral cortex, basal ganglia, thalamus, brainstem, and cerebral white matter. Thus, high sensitivity of both anatomical and functional detail. Since HIE mainly involves internal capsule and basal ganglia, now we will discuss about the anatomy of the internal capsule. Coming to the parts of the internal capsule, it consists of anterior limb, genu, and the posterior limb. Anterior limb of the internal capsule lies between the caudate nucleus and the lendiform nucleus. Lendiform nucleus is formed by both globus pallidus and the putamen. And the genu lies in between the interventricular foramen and the middle part of the lateral lendiform nucleus. And the posterior part of the internal capsule, which is most important, lies between the thalamus and the lendiform nucleus. And depicting the same picture in the MRI brain. This is the caudate nucleus which lies lateral to the frontal horn of the lateral ventricle. And this is the internal capsule, anterior limb, genu, and the posterior limb. The innermost part will be the globus pallidus, which will be palar in structure, and the outermost part will be the putamen. Both together forms the lentiform nucleus, and the thalamus will be in the lowermost area near the third ventricle, near the body of the third ventricle. And another one pattern of injury, watershed predominant pattern, mainly involves the areas in between the anterior cerebral artery and the middle cerebral artery and the posterior cerebral artery. This is the predominantly the watershed pattern of injury will be involving these areas. And in the cut section of the brain, it will be involved in the supromedial part of the cortex, followed by the subcortical white matter. And the most predominant injury will be mostly involved in the proximal limb weakness, followed by cognitive impairment. And in the MRI brain, this area will be in the supromedial part of the cortex, and mostly it will be affecting the parietal area on the occipital lobe and some part of the temporal lobes. Comparison of T1, T2 West flare. In T1 weighted images, the gray matter will be gray and the white matter will be white and the CSF will be dark. Complete opposite in T2 weighted images, the gray matter will be white and the white matter will be gray and the CSF will be white. Flare is nothing but the T2 weighted image in which the fluid is attenuated, that is the CSF will be dark. In HIE, mainly flare images will be used because for the better delineation of the white matter and the CSF differentiation. Both white and here it will be difficult to interpret. For that, flare images can be used. And another one part is the diffusion weighted imaging and the ADC maps. Diffusion weighted imaging is nothing but the restriction of diffusion will be shown as bright in the MRI pictures, and the CSF with the increased diffusion will be shown as dark. Complete opposite will be the apparent diffusion coefficient mass, that it will be dark in diffusion restriction and bright in CSF. Here it will be full white and the CSF will be dark, and complete opposition brain will be dark and the CSF will be bright in the ADC maps. Normal MRI findings in term neonates. Usually in any term neonate, there will be relative T1 hyperintensity, that is the area will be white in medial globus pallidus, posterior limb of the internal capsule, ventrolateral thalamus and the perirolanthic cortex. And it will be hypointensity, that is in T2 weighted images, there will be little bit dark or iso intensity in putamen, posterior limb of the internal capsule, ventrolateral thalamus and the perirolanthic cortex. This is the normal picture showing in T1 weighted images. There will be normal hyperintensity of the posterior limb of the internal capsule because of the myelination. This is the flare showing there will be hyperintensity in the posterior limb of the internal capsule. And in T2 weighted images, it will be either hypointensity or isointensity compared to the adjacent gray matter. T2 weighted images, it will be little bit dark. This is another picture showing T1 weighted images. This is shown as mild bright compared to the adjacent gray matter. And in T2 weighted images, it will be dark. Then coming to the MRI and HIE sequence, and for neonatal imaging, the optimal timings were there. In the initial 24 hours of life, MRS is the diagnostic method used, and 24 hours to 5 days of life, diffusion weighted imaging can be used, and after that T1, T2 weighted images of MRI brain can be used. This why within 24 hours MRI spectroscopy used, in there will be lactate elevation because of anaerobic metabolism. After 24 hours there will be pseudo normalization because of resuscitation, and lactate levels will be coming to normal, and after that secondary energy failure will come into play, and again the MRI spectroscopy findings will give the sensitive findings. In diffusion weighted imaging, after 24 hours only, there will be restriction of diffusion, mainly due to edema and the infarction. Followed up to 5 days, it will be the most sensitive method. After that, there will be pseudo normalization because of the capillary angiogenesis and mineral deposition. This pseudo normalization after 5 days will be prolonged in case of therapeutic hypothermia. And in MRS also, therapeutic hypothermia will be prolonging the duration. In T1 and T2 weighted images, both were there early and late. Early within 7 days and late will be after 7 to 30 days. Early imaging is used in to find out the acute timing of the injury and the areas involved, and late MRI brain images is used to predict the outcomes and the gliosis and the areas involved. Coming to the MR spectroscopy, there are two types: proton MR spectroscopy and phosphorus MR spectroscopy. Proton MR spectroscopy is most commonly used. It has high specificity, especially within 24 hours. In HIE, lactate, which is a marker of anaerobic metabolism, will be elevated, which is shown as doublet peak at 1.3 parts per million, and it will be associated with inversion of lactate peak. This is the main differentiating feature because the lipid peak will also occur at 1.3 parts per million. And the lactate bar N-acetyl aspartate ratio is the most accurate biomarker for prediction of outcome. While interpreting MR spectroscopy, gestational age and timing should be considered because in preterm neonates, usually there will be elevation of lactate due to the immaturity of the enzyme systems, and timing also should be considered while interpreting MRS. This is the phosphorus MR spectroscopy, usually used after 24 hours. It is the high energy phosphates, mainly phosphocreatinine and ATP. After 8 hours, that is once the secondary energy failure sets in, the phosphocreatinine and ATP values declines. It is valuable in the detection of post-ischemic increase in the intracellular pH, which correlates directly with the brain injury. This is the MR spectroscopy in a normal term infant. Amplitude in the y-axis and frequency in the x-axis. This peak is the myoinositol peak, and the next one is the choline peak, which is abundantly present in the brain, and next is the creatine peak at the 3 parts per million, and next at the 2 parts per million will be the N-acetyl aspartate peak. Usually lactate will be minimal or won't be visible, but in HIE infants there will be the double lactate peak at 1.3 parts per million. Adjacent to the lipid peak will also be there, but this lactate peak can be differentiated from lipid peak by the inversion of the lactate peak in another echo sequence. Usually this double lactate peak is mainly due to the methyl group of the lactate. And after that 24 hours, there will be N-acetyl aspartate peak will be, the amplitude will be reduced. This can be shown as N-acetyl aspartate peak is reduced in the following days. Lactate peaks and decreased N-acetyl aspartate peak is used to indicate the severity of brain injury. Coming to the diffusion weighted imaging in HIE, it is useful in early days up to 5 days. It can be prolonged in therapeutic hypothermia up to 8 days. Restricted diffusion will be there after 24 hours, and it increases over the next several days. False negative can be occur once we take the diffusion weighted imaging after 1 week. It is altered in therapeutic hypothermia, and diffusion weighted imaging should be always evaluated in conjunction with ADC maps, because in diffusion weighted imaging only there will be subjective variation, but in the ADC maps we can measure the quantitative values we can obtain and can predict the outcomes. This is the diffusion weighted image showing the decreased diffusion in the frontal cortex and the basal ganglia, shown as white. And this is another picture showing decreased diffusion mainly in the basal ganglia and the thalamus. And this is another one showing decreased diffusion in the hippocampus and the midbrain tegmentum. In apparent diffusion coefficient MAC, when the diffusion weighting image is applied to tissues, it is described as apparent diffusion coefficient. It is measured in millimeters square per second. 15% of HIE babies have normal values if the insult occurred before delivery. ADC values will be decreased by 5% in therapeutic hyperthermia, and the ADC values used in prognosis of HIE, mainly the values from the basal ganglia region and the thalamic and the posterior limb of internal capsule region. This is the ADC image showing restricted diffusion over the whole of the cerebrum except the cerebellum, which is shown as white. Here the cerebellum is paired and the whole of the cerebrum is affected. Patterns of HE depending on the timings and the duration. In acute, it will be less than 10 minutes in both the cases, prolonged 15 to 25 minutes. In acute cases is most common during childbirth and usually no significant or clinical or imaging sequelae. In prolonged cases, there will be shunting of the blood mainly to the vital structures resulting in peripheral or watershed pattern of injury. Coming to the severe cases, in acute cases, there will be mainly BGT lesions, and in prolonged cases, global pattern injury will be seen. And the patterns based on MRI, BGT lesions is the most common pattern involved, followed by watershed predominant pattern, and BGT lesions up to 60 to 80% involvement. Watershed predominant pattern is 40 to 60%, and global pattern in 20% of the babies. Depending on the pattern of injury seen on MRI and the type and the severity of the insult, most common pattern of injury following acute fetal distress during labor and delivery will be involved in the following areas: basal ganglia, thalamic, brainstem, hippocampus, the corticospinal tracts around the central fissure, the central cortico-subcortical involvement. And infants with chronic, possibly repetitive insult will be showing abnormalities mainly within the cortex and the white matter. During the first week after delivery, the following 6 main areas of abnormality may be identified on MRI in infants who fulfill all the criteria for HIE. Now we will be seeing one by one. The 6 areas mainly involved are, the first one will be the brain swelling, and followed by that loss of normal signal in the posterior limb of the internal capsule, and followed by that abnormal signal intensities in the basal ganglia, brainstem lesions, loss of gray matter white matter differentiation, and cortical highlighting mainly in T1 weighted sequences. This is the brain swelling may appear during the first 24 to 48 hours following an asphyxial episode. This is the normal T1 weighted image brain showing better delineation of sulci gyri, and the interventricular and the lateral ventricles are visible nicely, and there will be relative hyperintensity of the posterior limb of the internal capsule. And following in brain swelling, there will be the loss of the extracerebral space, loss of the sulcal markings, and closure of the sylvian fissure. Fissure is not visible, and narrow interhemispheric fissure, and slit-like anterior cone of the lateral ventricles. And coming to the posterior limb of the internal capsule, this is one is the normal hyperintensity seen. 15 to 30% of the babies will be having normal posterior limb of the internal capsule with the normal myelination. And this one is the absent posterior limb of internal capsule. That is, there will be no hyperintensity in T1 weighted images. It will be either isointensity or looking like absent posterior limb of internal capsule. And in severe cases, there will be reversal. The T1 weighted image will be showing the darkened area and the posterior limb of the internal capsule. Exactly opposite in the T2 weighted images, there will be relative hyperintensity in the posterior limb of the internal capsule compared to the adjacent gray matter. Usually, normal babies, it will be hyperintensity, dark. In T2 weighted, it will be opposite. And in diffusion weighted images, we can show the loss of that is a loss of restricted diffusion, which is shown as a bright areas in the posterior limb of the internal capsule in all 3 planes. Then coming to the basal ganglia and thalamus, the basal ganglia include the head of the caudate nucleus, globus pallidum, and the putamen, which together forms the lentiform nucleus. It is most commonly affected area in severe acute asphyxia. Why means due to the increased metabolic rate of this region, which is actively myelinating at time, and there will be high proportion of excitatory amino acid receptors. Abnormal signal intensity is most frequently seen within the posterior part of the lentiform nucleus, mainly putamen, and in the region of the ventrolateral nuclei of the thalamic. It will be gradually increasing over the first week. Then coming to the grading of the basal ganglia and thalamic lesions, in mild BGT lesions, there will be normal signal intensity of the posterior limb of the internal capsule and only focal hyperintensity seen in the ventrolateral nuclei of the thalamus and the globus pallidus. This is the FLAIR image showing hyperintensity of the internal capsule, which is normal. Only the focal involvement of the globus pallidus and the ventrolateral nucleus of the thalamus. Second one is the moderate BGT lesion. Here the posterior and lateral lentiform nucleus and the thalamus is involved, followed by the normal hyperintensity of the posterior limb of the internal capsule is lost. This one is the moderate, and in severe lesions, all areas including the caudate head and caudate nucleus will be involved, followed by midbrain lesions can also occur. Whole of the BGT area and the internal capsule is involved. Here the caudate nucleus is involved. And this is the sagittal curve showing the T1 weighted image showing the hyperintensity in the putamen and the thalamus. Depending on the BGT lesions, it can be divided into mild, moderate, and severe, which is formulated by Martin and his co-workers. Whether first we have to see whether the posterior limb of the internal capsule is normal or equivocal sign. If it is normal, baby's motor outcome will be good. That is walking at 2 years of age. In equivocal, there will be some late starters, and depending on that, 5 parameters are involved: feeding, speech and language, vision, developmental quotient, and seizures. Feeding 10% will be involved, speech and language 25%, vision mostly spared, developmental quotient more than 84 in 80% and more than 70-90% of the babies if the posterior limb of the internal capsule is normal. And depending on the cortical lesions, the percentage will be varying from 3 to 19%. Moderate also, we have to look at the mainly at the posterior limb of the internal capsule, equivocal or abnormal. Depending on that, feeding problems will be increasing from 10 to 50%, speech and language in 25% babies involved, vision 20 to 55% will have some visual impairment, and developmental quotient will be decreased up to 50%, and seizures will be classified depending on the involvement of the cortex. Severe BGT lesions, mostly feeding, speech, vision will be greatly affected, and the DQ cannot be assessed because of their motor impairment at this age, and seizures will be severe. Up to 75% of the babies can get severe seizures. Then coming to the next pattern, watershed predominant pattern. This is the second most common pattern, a classical parasagittal region involving the territory between the major arteries. It is usually associated with hypotension or partial hypoxia of prolonged duration, that is more than 15 minutes. Here the blood will be running mainly from the anterior to the posterior circulation occurs because to supply the brainstem areas. Seen in cerebral cortex, subcortical white matter, parieto-occipital and posterior temporal lobes will get involved. Predominantly cognitive impairment and followed by the proximal involvement will be there. This is the picture showing diffusion weighted image showing restricted diffusion in the.
Just a minute, Dr. Reena.
Yes, sir.
Hello.
Yes, sir.
Before going to the watershed pattern, maybe if you are not breaking that, maybe quite lengthy. Go back to the previous slides.
Previous slide. Oh, okay, sir.
Previous slide. That one, severe BGT. Severe BGT.
Okay, sir.
Severe BGT. So in that, if severe basal ganglia is involved,
Yes, sir.
what is the chance that the baby will not have any CP?
Severe BGT. 2%.
Only 2%. That is a high thing. Go back to the similarly. Go back to the moderate.
Okay, sir.
Moderate BGT lesions. There, even if the plic is abnormal,
Yes, sir.
what is the CP percentage?
Equivocal means 60%, sir. Abnormal means
abnormal plic.
75%, sir.
Okay, still 25% can be normal in a moderate BGT. Moderate means
Yeah.
already the basal ganglia
Extremely
is
involved.
extensively involved. The putamen globus pallidus is involved, the ventrolateral thalamus is involved, plic is involved, plic is abnormal. Even then, there is a 25% chance that because we don't have much evidence, moderate BGT lesions predict a very high risk. 70% is a very high risk.
Yes,
Still,
sir.
we have to keep in mind that it could be still a 25% normal. Because differentiating moderate BGT and severe BGT is a little tougher task unless you put a correct scoring system. Because here also, most of the basal ganglia will have a larger lesions. You want any comment on that? How to clearly differentiate moderate BGT lesion and severe BGT lesions? Because severe means it is almost
On the midbrain
over.
and the hippocampus,
Invariably,
other
CT will be there.
areas, other areas will be also involved, sir, apart from the BGT and the plic, hippocampus midbrain will be involved.
Other area involvement, okay, that indicates a severe HIE lesion, but severe BGT versus moderate BGT. You already told.
Usually, putamen and the ventrolateral nucleus of thalamus will be involved, sir. In the severe BGT, whole globus pallidum also get involved, and the caudate nucleus also will be getting involved in severe BGT.
Particularly caudate use out there. Caudate we have to look for. If it is also involved, probably it is a severe BGT. You have to clinically correlate whether it causes acute and severe HIE. So the thing is, the MRI brain can look at the lesions, but still 20% can be normal in a moderate BGT. And finding this correlating this clinical imaging versus our prognosis should be done very cautiously, and we need to be double sure about our imaging findings. That's a thing I wish to stress. Keep on based on the plic involvement. It can be because internal capsule contains. Why plic involvement produces CP?
Corticospinal tracts will be passing through the posterior limb of the internal capsules.
Which part is passing through that plic? Which parts fibers are more dense at that area?
Lower limb.
Lower limb. So cerebral dysplasia will be more common. The BGT alone is involved. Plic is preserved means?
Cognitive motor involvement will be less. Involvement will be less.
No. The basal ganglia is concerned is an extrapyramidal system where you can get a dyskinetic CP, motor coordination, all these things will be there. There also you can get a increased tone. That's extrapyramidal involvement. Here the pyramidal tract is dense at the plic, where you can definitely get a pyramidal tract dysplasia like lesions. Okay. Cortex, we can look for the other things like visual involvement or seizures. Like that. Okay. We proceed. Thank you.
Okay. This is the watershed predominant pattern showing decreased diffusion mainly in the occipital lobes, which can be seen as bright areas, and in the ADC maps it will be shown as dark areas.
Okay.
Next will be the brainstem lesions, that is the global injury pattern. Here, the stage 3 hypoxic ischemic encephalopathy usually have severe basal ganglia lesions with extension into the midbrain, pons, and medulla. The clinical state of an unarousable infant with no gag reflex, no facial expression, and no normal eye movements. The site of lesions within the brainstem lesions may be seen as low signal intensity on T1 weighted images and high signal intensity on T2 weighted images. It is usually dorsal. And this is the picture showing, first picture is the T2 weighted image showing the wide brain pattern injury, that is the whole of the cerebrum is involved with elevated signal intensity in the whole cerebrum. and there is no severe correct delineation of circle and gray markings. Same picture showing the whole of the cerebrum is showing restricted diffusion, and in the ADC maps we can see only the cerebellum is paired. For this type of lesions, ADC maps can be used because we will be thinking the whole of the cerebellum is involved, but in the ADC maps we can clearly see that the cerebellum is paired, which can be used in the prognostication. The next one will be the laws of gray matter and white matter differentiation. In T1 weighted images, here there is loss of differentiation for gray and white matter in the parietal lobe and the occipital lobes. In T2 weighted images, it is shown as bright intensity in temporal and the occipital lobe. And in diffusion weighted imaging, there will be high signal intensity, that is restricted diffusion due to cytotoxic edema in temporal and the occipital lobe. The newborn cortex has a relatively short T1 and T2 compared to adjacent white matter. This difference lasts for approximately 3 months. In perinatal asphyxia, this shortening will be further exaggerated. In mild asphyxia, cortex around the central fissure will be shown as high signal intensity. In moderate, around the central fissure, interhemispheric fissure and insula, the area between the external capsule and the claustrum, and in severe, entire cortex is involved. Grading can be done using flash sequence. Grade 1 is the high signal intensity in the central fissure, which can be shown both sides. And in grade 2, there is high signal intensity in the insula, and the subjacent white matter will be shown as dark, that is low signal in white matter. Low signal white matter and high signal intensity mainly in the insular region. And grade 3, there will be hyperintensity at the level of central semi-oval, which is the white matter adjacent to the lateral ventricles. Highlighting of the gyrus sulci around the central semi-oval. And in another grade 3 also, there is a low intensity in subcortical white matter adjacent to the highlighted cortex. Here the cortex is highlighted, shown as bright images, and adjacent to that subcortical white matter will be dark. And in T2 weighted images, it will be shown as low signal intensity in the cortex, shown as dark, and high signal intensity in the white matter areas. Coming to the cerebellum, relatively resistant to HIE, dentate nucleus is sensitive to asphyxia. In total brain injury, white cerebrum sign will be seen. And this slides I already have described. Here the dentate nucleus is involved. Coming to the MRI brain, in preterm neonates, white matter injury is more common, which may be leading to the secondary dismaturation of gray matter structures. White matter adjacent to the trigone and the posterior border of lateral ventricle is most commonly involved, and left hemisphere is more involved than the right. It can be classified as diffuse white matter injury, will be occupying the most of the lesions, followed by micronecrosis 35% and PVL remaining 8%. In coming to the diffuse white matter injury, there will be a special entity called diffuse excessive high signal intensity in case of preterm babies, and the acute white matter injury will be associated with decreased ADC values, and chronic white matter injury will be associated with increased ADC values mainly due to the cyst formation. Here there will be decreased ADC values mainly due to ischemia. This is the T2 weighted image showing abnormally high diffuse excessive high signal intensity. Here we can see in this occipital lobe area, here we can see diffuse excessive high signal intensity, hyperintensity. And coming to the PVL, it can be graded into severe, moderate, and mild. Severe will be cystic form, large areas of macroscopic necrosis evolving to cyst, and the degree of white matter injury will be severe. And in the images, we can see the cystic. Moderate non-cystic areas, usually small areas of macroscopic necrosis evolve into gliotic scarrings will be there. Pattern of injury is intermediate, and periventricular signal abnormality on ultrasound, and in pandate white matter lesions on MRI brain. Mild there will be microscopic area of necrosis, which is usually not seen in the MRI brains. For that, functional MRI pictures can be taken. This is the picture showing cyst lateral to the supralateral to the lateral ventricle. This is a T2 weighted image showing gray matter white and white matter gray. This is the cyst. Both sides the cyst is seen in the supralateral to the lateral ventricle. And in the moderate PVL areas, there will be pundate white matter lesions in T1 weighted images near the ventricles mainly. And in the severe stages, there will be squaring of the lateral there will be squaring of the lateral ventricles due to incorporation of cysts and the loss of the white matter volume around the ventricles. Clinical correlates of immature white matter injury, long-term sequelae of periventricular white matter injury, including corticospinal tracts, optic radiation, and association fibers. There will be spastic diplegia or quadriplegia associated with visual deficits and cognitive deficits. Coming to the MRI scoring.
Just a minute, Dr. Reena.
Yes, sir.
You have seen that MRI grading of mild,
sir.
moderate, severe, and periventricular leukomalacia, you were told.
Yes, sir.
Is there any difference between our ultrasound commonly done for grading PVL and this one, MRI?
Yes, sir. In ultrasound, there will be first grade 1 will be clear, persisting for 7 days. And in grade 2, fronto-parietal regions will be usually involved. Grade 3, temporal and occipital lobe also will come into play. In grade 4, cystic whole.
What will be involved? What findings will be there? Fronto,
echogenicity for inside will be cyst, sir.
Cyst formation will be there. So cyst formation is graded as grade 2, 3 like that in ultrasound, whereas cyst formation itself is severe in MRI brain.
Yes, sir.
That's a major difference has to be kept in mind.
Okay.
When cyst is identified in MRI, it indicates probably a severe grading. You go back to that classification. Okay. You should have put that reference for this classification. It's taken from
Volpe, sir. Volpe, 6th edition.
Put that article, now that will be better rather than telling the book.
Okay.
Anyway, so that. Hello. Go back.
Yes, sir.
Go back to that classification. That is why non-cystic here, even non-cystic, which is moderate as a. This is incidence or prognosis, approximate incidence you have put.
Incidence, sir.
Incidence finding
sir.
only you have put. Prognosis percentage was not put.
No, sir.
Okay, we'll talk about later. Okay, proceed. Thank you.
And coming to the MRI scoring system for HIE, relationship between MRI scoring system and neurodevelopmental outcome at 2 years in infants with neonatal encephalopathy. 3 scores are most commonly used. First one will be the Barkovich score. It will be taken in T1 and T2 weighted images. In NICHD neonatal research network score, T1, T2 weighted images were taken into account. In Beaky score, multiple parameters were taken into account, including spectroscopy, white matter injury, cerebellar injury associated with any hemorrhages, intraventricular hemorrhage, subdural hemorrhage, and cortical sinus venous thrombosis. Now, today I will be dealing in detailed discussion will be on NICHD neonatal research network score. Normal will be normal. Pictures will be shown in 1A and 1B minimal, only cerebral lesions will be seen. In 2A and 2B, BGT involvement will be there. And in 3, whole of the cerebrum will be involved. In score 0, that is normal. In sagittal cut, this is the normal sagittal cut showing normal brain MRI. And in the axial, cut T1 weighted image, there is the usual hyperintensity of the posterior limb of the internal capsule, and in T2 image there is a relative hypointensity or isointensity of the posterior limb of the internal capsule. In score 1A, only minimal cerebral lesions. In sagittal cut T1 weighted image, there is pundate white lesions. You can see as white dots. In T2 images, it is shown as hypointensity lesion, shown as dark dots. This is score 1A, minimal cerebral lesions. In score 1B, that is flare is taken into account, flare image, more extensive cerebral lesions without other involvement. In axial flare, there will be bilateral hyperintensities in the cerebral area and the subcortical white matter, and the coronal cut, there is a bilateral hyperintensity shown in flare. In 2A, basal ganglia, thalamus and the internal capsule lesions occur. In axial T1 weighted images, the normal hyperintensity of the posterior limb of the internal capsule is not seen. The associated with the hyperintensities in the thalamus and the lendiform nucleus. Same thing in the T2 weighted images, there will be high intensity in the posterior limb of the internal capsule associated with the thalamic regions will be having hypointensities. In score 2B, in axial cut, there will be high intensities that the whole of the BGT will be involved associated with the cerebral lesions. And in axial T2 images, there will be diffuse white matter, high intensities. In score 3, whole of the cerebrum is involved. This is a flare image showing low intensities in T1 weighted, that is shown as dark areas. Same thing in the T2 weighted images shown as a bright, high intensities. Whole of the cerebrum is involved. Coming to the differential diagnosis, the most common one will be the acute bilirubin encephalopathy. History will be taken into account, followed by that in acute bilirubin encephalopathy, globus pallidum will be involved mostly. In flare image, it is shown as hyperintensity lesion, and in T1 weighted images, here the globus pallidum will be, hyperintense globus pallidum will be seen. In maple syrup urine disease, in T2 weighted image, there will be hyperintensity in the posterior limb of the internal capsule due to edema. And it can be correlated with the MRI spectroscopy showing branched chain amino acids peak next to lactate at 1 parts per million. And in non-ketotic hyperglycemia, there will be hyperintensity in the posterior limb of the internal capsule. Restricted diffusion here also due to edema, and there will be many areas of the brain will be involved, mainly pons and the midbrain also will be involved in non-ketotic hyperglycemia, and there will be glycine peak in MRI spectroscopy. In urea cycle disorder or ornithine transcarbamylase deficiency, mainly T2 weighted images, there will be hyperintensity of the white matter. Whole brain showing diffuse edema shown as a diffuse white matter. There will be hyperintensity of white matter. Conclusion. In HIE, characteristic MR imaging patterns vary according to the degree of brain maturity and severity of the insult. MRI findings of HIE have great prognostic value and should be always correlated with the diffusion weighted imaging and ADC values because of subjective variation in diffusion weighted imaging. And when clinical history and clinical findings are unusual, metabolic and infectious diseases should be always considered. References, following are the references. Thank you. Sir? Hello?
Hello, Meru. Hello.
Yes, sir. Yes, sir.
I think Ashok sir is there. He's still there.
No, sir.
I can see him joined actually. Anyway,
Okay, sir.
quite a elaborate and good presentation. First of all, congratulations for that.
Okay, sir.
And now, if you want to highlight a few points from this from your presentation, what are the important points would you like to highlight? Now, what is a normal plic?
Posterior. What, sir?
Normal plic
Posterior.
sign.
Yes, sir. Posterior limb of the internal capsule will be myelinated at term newborns. But while we are interpreting in preterm neonates, we have to correlate with that because the timing is at 37 weeks only. Myelination starts at the posterior limb of the internal capsule. So it will be shown as hyperintensity in T1 weighted images, and T2 weighted images, it will be hypointensity or little bit dark compared to the adjacent gray matter.
Can you show that
Yes, sir.
thing?
Yes, sir. This one will be the normal one, sir. Hyperintensity in the posterior limb of the internal capsule in both flare and T1, and it will be relatively isodensity or hypointensity in T2 weighted image.
Basically, it whatever will be the CSF color, opposite color will be the internal capsule color normally, isn't it?
Yes, sir.
If T1 mein CSF is black colored, right?
Yes, sir.
So the internal capsule should be normally
Opposite.
white color.
White color, sir.
Yeah.
Myelinated. Mainly posterior
Yes.
limb will be myelinated at term.
So if the CSF and the internal capsule both appear with the same color, means it is abnormal.
Yes, sir. Yes, sir. For
That's
better
how
for better interpretation, flare image sequence can be used, sir.
yeah. So this is one important point everyone should remember, I guess, because that is what is important for prognosis. And someone has asked question in the chat box. I can't see any question. Ideal timing of MRI in HIE.
Ideal timing will be after initial 24 hours MRI spectroscopy, sir. After 24 hours to 5 days, there
So
will
that's
be diffusion weighted imaging. And after that, T1 and T2, early MRI there and late MRI there, sir. Early MRI is mainly used to identify the area of insult and the severity of the insult. While late MRI, we can predict the outcomes. But early MRI has shown better sensitivity and specificity. But late MRI have high sensitivity in predicting the outcomes, sir.
okay. Yes, that is quite great. Anyone is having any questions? Kindly please ask.
The timing recently we used to say, hello.
Yes, sir.
Timing usually because of stability, units will take after week 7th day. But now, recent articles have pointed out that after the cooling is over, at 72, after the 3rd day, 4th day, MRI prognostication is not much different from that of the 11th day. So articles have come up. You can verify in Acta Pediatrica 2015. So after this cooling studies, they are saying that the early MRI after that, in the first week, 4th day, is a equivalent as that taken in the 2nd week, 10th or 11th day. But the other things like the other sequences should also be kept in mind. How to interpret the pseudo-normalization in diffusion weighted images should be taken care of. One. This is for term or the late preterm neonates. For the preterm neonates, you have pointed out that diffuse enhancing high signal intensities.
Yes, sir.
They are very common if you are taking it very early. Even normal preterm infants may have this diffusion enhancement of high signal intensities. in the first week. So if there is no cystic lesion, we need to follow up. We need a follow-up MRI to be taken either after the second week, or we have to take an MRI at the term equivalent age. Or if MRI is not possible, we have to do sequential cranial ultrasound. That has more predictive value, because initially system may be absent in the first MRI. If you are taking it in the first week, only diffusion enhancement may be seen. But subsequently, system may develop, and in the last term equivalent age, even some of the system may regress. So collectively, the pattern of evolution has more importance in predicting the neurologic outcome rather than a single flip. Even if you are taking a MRI, that is not going to tell you a clear prognostication. It all depends on the timing, and the associated previous ultrasound findings also very important. Because if you take too late, some of the system may not be seen. That does not mean it is an improvement. But the earlier white matter injury, we might have not taken an MRI. We have to check the previous ultrasound results. This has to be kept in mind for interpreting the preterms.
Yes, sir.
Okay. Any other questions?
Hello, Reena.
Yes, sir.
Can you show that slide that you have shown that that profound
Yeah.
asphyxia?
Profound aspect.
Somebody has asked lactate peaks in MRS.
Okay, sir. I will show. This one, sir, doublet peak. Double peaks will be in the HIE babies at 1.3 parts per million. That area there will be double peak due to the methyl group of the lactate.
No, it is not 3 parts. It is nearly close to the 1.2 or 1.5, I think, lactate. You can see the number here. 3 is on the
1.
left side.
Other, sir, 1.3 or 1.3, sir.
You initially said 3. That's a 1.3
1.3, sir.
parts per million.
Oh, yes,
So
sir.
I have not, because of net issues, I have not seen this slide, but I hope you have talked regarding how these metabolites are
Yes, sir.
taken. The first one is the myoinositol.
Myoinositol. Yes, sir.
You can, for easy to remember, there's a mnemonic given in some other text. And mycol,
My.
like a chocolate name,
Okay.
colcrane nala, like that. Chocrea, or even if you leave the choline L, it will be just like a chocolate name. Chocrea nala. Na for this N-acetyl aspartate, and the La for this lactate. First one is the myoinositol.
Myoinositol. Yes, sir.
My Chocrea nala, that was given easy to remember. And the lactate will be the lower one, where you have to look for lactate. Okay, anything else? Any other questions we can check? There is no other question. I think we can wind up.
Okay, sir. Thank you, sir.
Thank you all. Good presentation.
Thank you, sir.
Thank you.